Everybody, welcome to our critical care medicine section. At the top of our meetings, we discuss a clinical scenario, and today we're going to discuss the agitated patient and people's different approaches to it. So I hope you enjoy. All right, Dr. Wu, hit it.
Excellent. Thanks, June. So I want to pose a clinical scenario that I think all of us have seen at least once in the emergency department. I feel like I see like maybe once a month. So here it goes. You got a 36-year-old male who gets brought in by EMS. Comes from the scene of an unwitnessed car crash. He's wandering around the car. They think that he was probably the driver, although they're not sure. Airbags went off. Car is severely damaged by the car crash. He's got some superficial injuries, but the bigger issue is that he is severely agitated. In fact, when he comes in with police and EMS. He's handcuffed to the stretcher. EMS has tried several times to get an IV in him. They can't get an IV in him. At this point, he is agitated, can't be redirected. He's attempting to hit staff, and he's trying to get off the stretcher. At this point, what is your next management? What is your drug of choice to help manage this patient? And I think this is something that I run into, I feel like once a month at a trauma center. This patient comes in, not sure what's going on with him. He may be head injured. He may be just intoxicated, but I don't really know what to do with him. And that's something that I frequently struggle with. Of how do I manage this patient and get the workup done, but not end up having to intubate him? Because really, if he doesn't have any injuries, it's going to create more headache if I intubate him. So, interestingly enough, there's been a randomized control trial in the last couple of years that actually looked at this very question. What is the best IM agent to control an agitated patient who is in the emergency department? There's been a lot of analyses looking at prospective observational trials. There have been retrospective chart reviews, but randomized control trials are really hard to do in this patient population. We really don't have a lot of evidence of what to do with these folks. Fortunately, it turns out someone did a randomized control trial on this. So what we're talking about is the Intramuscular Midazolam, Olanzapine, or Haloperidol for the management of acute agitation, a multicenter double-blinded randomized control trial by Esther Chan et al. This was published in eClinical Medicine, not a journal that I think a lot of us read on a typical basis. But what was interesting is that this is actually the only randomized controlled trial of use of IM Olanzapine versus Midazolam versus Haloperidol out there. In fact, one of the very few randomized controls of any IM drugs in the emergency department. So I'm going to summarize the paper real quick. This was a multicenter double-blind randomized controlled trial. The patients were block randomized to either receive 5 milligrams of olanzapine, 5 milligrams of IM haloperidol, or 5 milligrams of olanzapine, midazolam, or haloperidol. Patients could be redosed for a second dose for a total of 10 milligrams. Treating providers were also allowed to use other drugs if they thought were appropriate. Patients were then given these drugs upon presentation in the emergency department, and then only were consented after the fact. So interestingly, the IRB for this study allowed them to get consent after enrolling patients in the trial. This is something that's very unusual. You don't see in a lot of trials, and I think is worth commending these authors for. Patients were then analyzed. The primary outcome of this trial was control of agitation and proportion of sedation at 10 minutes, and then they were tracked for every 10 minutes, 20 minutes, 30 minutes, 45 minutes, and 60 minutes. How many patients were adequately sedated by that time? They were able to enroll 206 patients. 167 were able to get consent, which is pretty good. With 56 patients in the midazolam arm, 54 patients in the olanzapine arm, and 57 patients in the haloperidol arm. They found that midazolam was able to achieve a significant degree of sedation at 10 minutes in 52% of patients, whereas olanzapine was only able to achieve agitation control in 34% of patients, and haloperidol was only able to achieve agitation at 21% in patients at 10 minutes. So by far, midazolam was the most effective. However, by 60 minutes, all patients were about 90% of patients were adequately sedated by the 60-minute mark with all three drugs, regardless of what they actually received. So all drugs work, but midazolam certainly worked the fastest. And that's one of, I think, the interesting takeaways from this paper. The other interesting takeaway from this paper was that if you looked at side effects, one of the big things that we worry about with haloperidol is the QT prolongation. I think many of us have gotten EKGs after giving significant amounts of haloperidol. And what they found, there was actually no real significant QT prolongation in any arm. In fact, there was the most amount of QT prolongation happened in the midazolam arm as opposed to the haloperidol arm. So again, an interesting result. And finally, 50% of patients in the midazolam arm fell asleep, whereas only 19% in the olanzapine arm and 30% in the haloperidol arm. And this was statistically significant. So definitely midazolam made the patients a lot sleepier. So not a huge trial, but I think an interesting result. And I think this made a lot of us discuss what do we do with the management of the agitated patient. So I'm going to turn to the group and say, what do folks use in these scenarios? What would you use to control your agitated patient?
So Greg, I think maybe we should start with you since you brought up this article. It's a great choice.
Okay.
What are you going with to sedate this patient to make it safe for you and everybody else to take care of them?
Yeah, I think it's fair. I will tell you that I am a huge olanzapine proponent. I think that this medication is frankly criminally underused. It is extremely effective at controlling agitation in my anecdotal experience. And certainly has the major benefit is they usually keep spontaneously breathing through all of this. I never have to worry about was this patient intoxicated at the same time, say with alcohol or opioids, and if I give them a benzodiazepine, are they going to stop breathing on me? With the olanzapine, they're all likelihood going to keep breathing, which is really my goal, is to keep them calm with airway reflexes and spontaneously breathing, but not to the point where I can't examine them and to the point that they're so sedated I have to intubate them.
June, I saw a lot of head nodding when Greg said that he's an olanzapine guy. So it looks like you might go with that. I'm curious what you make in this paper of the use of 5 milligrams of olanzapine instead of the recommended 10, and what dose you would normally go with for a patient like this.
Yeah, sure. So certainly I'm a big fan of the 10 milligrams. The way I look at it is if you're a small human being, I don't base on gender, I just like an eyeball. Are you small? Are you on the smaller side? You get 5, and if you're bigger, you get 10. That's what I tell my residents is. It comes in a 5 milligram vial, so that's your starting dose. But if you think it's a bigger person, give them 2 vials.
Do you have a reference person that you use for small and large?
That's an excellent question. I would say that if they are small, so my wife is 5'5". If they're smaller than my wife, they're kind of they're a normal to smaller size person. If they're bigger, taller than 5'5", then they're a bigger person.
Awesome. June, you look like you have a lot of thoughts on olanzapine. What are you thinking?
So I like olanzapine. I think in my subset of patients, most of my patients have IV access. And so giving them an IM med feels like extra punitive, which is always my hesitation. Although, many of our agitated patients are TBI patients, and there I'm trying to avoid Haldol. And so I like olanzapine. It just feels extra mean to give someone an IM shot. I use a lot of ODT Zyprexa, like Zydis, although that doesn't actually really help an acutely agitated patient. So this patient that you really, you don't have IV access and you need to control, I like the olanzapine. It's just that in the typical patient I care for on a regular basis, I have an IV. And so every time I don't use it, I think to myself, like, is that right? I'm not using it. I don't know what other people feel about that.
Awesome. Yeah, I love Zydis for my ICU patients that I'm trying to get them kind of more sedated during the day. Neil, you and I chatted a little bit, given that this was the trauma patient. What would be your indication you think to take the airway to get this person their workup done?
So can you hear me? Because
yes.
Yeah. Okay. Awesome. So I'm in a weird place. So I'm very county in Long Island. So we have a lot of heavily intoxicated people that come in with concern for trauma rather than trauma. So I mean, unfortunately, I missed the beginning of the case, so I don't know exactly how this presentation was, but I have a lot of fall with head trauma on very intoxicated people that don't have a lot of evidence of traumatic injury superficially. So I tend to slow play those patients, and I'm more happy to try getting some IV access, using some benzos. I don't have olanzapine, unfortunately, maybe some Haldol, in order to get them under control before they go to CAT scan. If I'm not getting it done quickly, I think the big thing that that Greg mentioned in terms of like the time of onset of these medications, your primary endpoint was looking at 10 minutes, and none of these drugs work in 10 minutes, right? Like if you need to control a patient in less than 10 minutes, none of these medications in an IM route are things that are going to be useful for you, right? You need a 20, 30-minute window where that patient can be monitored or, in 2-point restraints or able to be redirected until they get sleepy. I like getting IV access and using big doses of midazolam to get them under control. And if they need to get down faster, then I think ketamine's your drug of choice. And I don't think you can do it very many other ways. And if it's a trauma patient that you're genuinely concerned about and you need to get them under control in 10 minutes, absolutely, I'm taking that away.
Fred, you said in the comments that you've been a bigger fan of ketamine lately, so maybe I've won you over after a month of mulling over our discussion. What are your thoughts? Are you going to ketamine or are you going to use one of these?
So I think I'm still a purist. I mean, the pharmacokinetics of Versed just makes sense, getting stabbed through your gene. That I think in reality, there's enough people that it's a safety concern. I'm a big proponent of 4 of IM Versed to start. I think honestly, if you get a little bit apneic, then we can always try to support you through it, or you just end up with a definitive airway. But I think, yeah, like I have a little bit of an issue getting Zyprexa, so in the time it takes to get the actual Zyprexa, like they're either wiling out or don't need it anymore. And then, like June said, I could just give them an IV med. I think I moved away from the classic Haldol or B52 a long time ago. I wish Skylar was here, since Skylar's been writing so much stuff about Haldol lately. But I will say, yeah, I'll still use a lot of Versed, and then if I need total control right away, or if it's a one sort of poke type of person big enough that they're going to see it coming next time, then I'll just do 4 mg, like 4 milligrams or 5 milligrams of ketamine IM.
Matt, Fred brought up the B52. Since you're just getting started in your EM training coming out of the EMS world, are they still teaching the B52 back from way back in the day when we were all interns?
Yeah, they actually are still teaching the B52, but they're using Haloperidol instead now. I think it's interesting, between the trauma center and the quaternary center that we train at. The trauma center is actually a more advocate of using fentanyl first, because if the trauma is actually, agitation secondary to pain, we start with fentanyl first and then consider, like a Haldol or Zyprexa. Whereas the quaternary center, who isn't really a trauma center, will actually go to like Haldol first. So not even Versed.
Elias, hearing about using fentanyl first for this situation almost gave me a heart attack and put me in your ICU. What are you using?
I mean, probably my shop is a little bit interesting because it has the surgeons involved, so some approval is required. I think Versed Haldol is probably the ones that they tend to reach for, but I sometimes would try Haloperidol as well, just because you can use an IM, IV, MPO as well, so you have an option if it works. So I'll try it sometimes as an option.
Is anyone seeing the QT prolongation with the antipsychotics, and how many doses are you willing to give before you start getting worried about it?
I mean, I usually don't really care. Like, if you're just using 1 or 2 times for acute agitation, the likelihood of changing QTC is really low. And I can tell you, we've used massive dose of Seroquel together with amiodarone and all that other stuff that prolongs QT, and I mean, they might even start out in the QTC in the 500 range, but as long as they don't have any variations or changes, I don't really care.
Not to say that
I'll
you
get
know,
an EKG after 10 milligrams if I'm feeling nervous, and I don't even think about repeating it before 20 milligrams.
yeah. I'll say, you
I
know,
mean,
certainly not that anecdotes make evidence, but certainly I have been known to use 20 milligrams of olanzapine or haloperidol, and really, I mean, what they do is they get tachycardic, which is like perfect for QT prolongation, right? Their QT is going to start shortening again on you. They're not gonna get bradycardic. They're not gonna throw they're not gonna throw PVCs on you. That's gonna risk a Q1T event. It's kind of perfect. It's like a self-fixing problem.
Yeah. Kenny, what are you giving this agitated patient? Do you have some neat trick that we don't know yet?
So I think that we have a mix of what everybody's kind of discussed, really. I think that in our shop, we've gone more towards ketamine up front, IM or IV, and also droperidol. It's kind of a mix between the two. And then adding on Versed, kind of like everybody said, for our acutely agitated patients. We do still use Haldol and Versed or Haldol and Ativan. We don't have the B component of the B52, but we do still use that Haldol and Ativan. I think it's something that our nurses are just used to, and frankly, people upstairs that we admit to are used to as well too. So they prefer that sometimes.
The other nice thing about the B52 was that it's all compatible in the same syringe. So it's only one poke for the nurses, and it's less needles around an agitated patient that everyone has to worry about. But it seems like Ativan has maybe fallen a little bit out of favor, and a lot of people aren't using the Benadryl anymore. Is anyone doing different meds? You know, June, are you doing different meds depending on the situation? Like, oh, I think this is a native psychotic issue, so I'll trend more towards antipsychotics, versus this is an intoxication issue and I'll trend more towards benzos.
I mean, again, remember that I'm taking care of largely ICU patients, and so this is very different, right? You know, I use a lot of dexmedetomidine in my patient population, right? And so I think, yes, I of course tailor my drugs to the patient, but I have a lot more tools, a lot better access, and in a lot of cases, a lot more time, right? Like I am less like racing to get the patient imaged. And so I have time to have, you know, a gentler come down that takes longer, right? I don't bolus my dex. I don't know if anyone here boluses their dex. So, you know, it takes time to come on board. I would say I will use dex in an alcohol withdrawal patient. But I think it's interesting, right? Because an alcohol withdrawal patient is the one where I'm most likely to tailor my drug of choice to their particular disease process. But actually, you know, I'm most likely to use a benzo for them. I'm most likely to give them phenobarb. I'm most likely to give them dex, right? They actually, like, even though I say I tailor my drug to their disease process, they actually open up. I'd say I'm probably least likely to give them an antipsychotic. It's really the only time that I wouldn't reach for that right away. But I think, you know, it's fair, and when in thinking about this, that our patient population is just a little bit different.
Awesome. All right. So it sounds like we maybe don't have a definitive answer for what our go-to drugs are, except maybe one thing that we would all, or many of us would do differently, is if we're going to give olanzapine, we'd start with the 10 milligrams instead of the 5. And that seems also pretty consistent with the previous literature as a good way to go to get adequate control of our patients. And most of the stuff is probably going to work, and most importantly, keep the patient and all of our coworkers and nursing colleagues pretty safe. Anyone else have any other thoughts?
I just actually want to pose one more question. This is something so I was running this case by one of my colleagues earlier, and he said what his proposal was actually he would actually just drill an IO in the patient to give IV medications rather than go the whole IM route. Would you want to try to get an IO in a patient?
Not in an agitated. Yeah. The last thing we need is a bigger needle with a drill attached around a more agitated patient.
I think it's easier to
scarier.
Yeah, I think if I'm willing to risk it, you just just tie one arm down for an IV. I think as you come out with somebody with a drill, whether they're drunk or not, or schizophrenic, I think that just the sound of the drill is not going to make your life any better.
And I think, insofar as many of us favor antipsychotics, you actually have reasons to use olanzapine versus others. And so it's actually nice to be able to use the IM route in this patient. So that's not something I would do.
Fair enough.
All right. Thanks for another great discussion, guys.
Thank you.